I think it's like a 60-year-old guy who's had a prior fusion by another surgeon. I think he used the standalone cage
Mm-hmm.
at the levels below at 4556, and he achieved solid fusion. This was done about 5 years ago. Then
Okay.
he started developing symptoms of myelopathy level above, because then he started having wearing out the levels above. You know, there's a spondy going
Mm-hmm.
on, and the X-ray, and you can see there's some spinal cord kinking at 3-4. This is pre-op CT. You can see there's some spondy going on here, and obviously there's a spondy, some slippage. I didn't want to stop the fusion here because, you know, this is already going bad here too.
Yeah.
So I didn't want to put a plate in here either because of the there's such a high force there, you know, at
Yeah.
that level. So I used a Amandia standalone cage, those two other levels, as you can see here. I made actually a separate incision on the left side, way up high. And I went in there and I did a C3, C4 ACDF, and I did a C2, C3 ACDF.
So can you go step by step, explain your C2, 3 incision from the skin down to the bone? Can you, if you can share, like, you know, just on your own neck or on a picture, show us exactly the step. I think that's a huge learning point.
I had the ENT check him out before, make sure both of his vocal cords are intact, because
Mm-hmm.
you want to go on the side. If there has been damage to the vocal cord, you want to go on the same side. So
That's
this patient had both vocal cords intact, so I went on the left side because I always go on the left side. You know?
So let me give a little, I think, since we are going to podcast this out, the recurrent laryngeal nerve goes all the way, make a loop around the major vessel down below, and comes back up and innervates our pharynx. What that means for our ACDF, that during the approach, because we are very close to that and it runs with the neurovascular bundle, we may damage it. Like, I'm a right-handed person and I always go from the right. Some people go always from the left. Either way, every surgeon can go either right or left. And the point is that if recurrent laryngeal nerve get damaged on one side, we don't even notice it in a regular exam, and it has practically no consequences. But if you damage it both sides, it's a catastrophic event. People cannot swallow, cannot talk, they cannot breathe even. So meaning that if a surgeon has done an ACDF from the left side, what I do on my side, I make sure that the ENT look with the endoscope to the vocal cord, because then you can see that one side of the vocal cord are limp. And if that is the case, I will never go from the right side. If it's already damaged on the left side, I will never go from the right side because the consequences can be catastrophic. So meaning that I still go from the side that is damaged. So because then the other healthy side is not a danger. But I think the uniqueness of this case is that doing ACDF in the C2, 3 is a completely different animal. This is not a irregular approach. This is a pretty big deal.
Once patient is positioned, you got to make sure that patient's neck is fairly extended, because you want to get the mandible out of the way. Obviously, I had extend, you know, the monitoring going on. So I put two bolsters in the back of the neck. You know, you got a couple here, you got to kind of tape it up like that. Important thing is you got to make sure that patient's completely paralyzed.
Mm-hmm. Absolutely.
You know what I mean? You don't want to fight the tongue. You don't want to fight any muscle contraction by the patient. You got to make sure patient has a zero twitches, absolutely flaccid, completely paralyzed.
Okay.
And I make incision at C3, C4 because I cannot make incision C2, C3.
Show me on your neck exactly where you did the incision. Dr. Kim goes always from the left, so you guys know.
Yeah, 5 finger breadth above, so it's from the middle line, somewhere way high here.
So on the mandible jaw, on the border of the mandible.
Yeah, just between, you know, just below the mandible and the midline.
And more, not exactly, you know, a little laterally, or did you start at the midline? or did you go a
Well,
little?
I always make it from the midline to the about 2 inch laterally. You know what I mean?
Got it. Okay,
So you
the
make
next
this.
step. At that point, sternocleidomastoid is far lateral, so it's not in your way,
exactly.
correct?
And then you do a
and omohyoid as well. It's below you. It's not in your way.
I don't have to mess around with the omohyoid.
Okay, so what is the next after the fascia? What is the next you see and dissect?
So we have to make a skin incision.
Okay.
Okay. So I make a skin incision, and I use a needle tip cautery.
Okay.
You know, fine point is a Megadyne needle protected needle tip. Okay. So I go to the needle tip, and over the years, I used to use a Cushing tooth held pickup to dissect through the tissues. And in this case, there's some chance that I might go into some bleeding. You know, so I have vascular clips, microvascular clips, and I use a DeBakey.
Okay.
Okay. I use a DeBakey. I use a fine Metzenbaum scissors, and I basically pick it up, spread, cut, pick it up, spread, cut. In this case, I did run into the some higher up branches of the external carotid artery, which is a facial artery and vein. Okay. Okay, and the superior thyroid artery and vein. So I had to clip those.
Yeah, I mean, and unilaterally, we know from our experience, you can clip and dissect them as you wish. It has no consequences. That's a pretty safe kind of approach to.
Yeah, so I'm kind of going from laterally to medially, and.
So may I ask you, under the fascia, under the platysma, you practically you just dissect the thyroid vessels, and then practically, I think you're very close to the anterior part of the C2, C3, correct?
Yes, yes.
In a regular ACDF, they are able to mobilize the pharynx and the larynx because it is mobile down below, but that high up, it is actually fixed to the floor of the mouth. And are you able to, when you go there, you go at an angle, but then are you able to swing it and be able to go straight down, or is it a difficult thing to do?
The problem is that as you go deeper, you get hung up by the most superficial structures. So I got a little bit exposed deep down there. I come back up to the superficial area, and I cut through more of the fascia and subcutaneous tissue and more superficial thing. Okay. Then you get a less resistance by the soft tissues, and then you gradually enlarge it like that.
I'm not sure if you guys know, probably there are less than 10 people on the planet able or willing to do C2, 3 ACDF. So this is a huge utility if you can to bring it that we in the Inspired Spine, we have experience with this kind of approach.
Well, C2 traditionally has been open mouth kind of transoral, but that is a high mobility. This patient was discharged overnight stay.
Okay, and that is the advantage.
Which is crazy because I use the Exparel on the back side. Yeah. So let me.
As well, I think what I need to say for the folk that are listening to this is that Dr. Kim was talking about the transoral approach. For the C2 approach, generally, what we do, we open the mouth, we go to the back of the mouth, we cut it vertically, and then once we push the tissue away, we are actually anterior to C2, 3, where Dr. Kim was describing, but that by definition exposes the tissue to the flora of the mouth. In some cases, if you need bigger approach, which is done, and I have done those surgery in my residency time, we even split the jaw. We literally cut the jaw, and we open up the jaw with the ENT help, and then you have a much bigger approach. But these surgeries, none of them is a surgery that patient go home next day. So the utility of this is, if you can do it technically, is that you get all the benefit of the ACDF, which is faster recovery, faster discharge, and so on, but technically it's very challenging. Okay, if you want to make it bigger, you can just go ahead through your steps now, through your...
Okay, so you can see this is the post-op x-ray. So that approach, 2-level ACDF, it took me about 2 hours to finish the procedure with just no real bleeding, okay? Something like this revision, I always use a tranexamic acid, TXA. I give him a 1 gram, and that basically knocks out all the, venous bleeding, oozing, and all of that. So I lost 5 cc of blood from 2-level ACDF in the front.
Okay.
Then I flip the patient over, and I just put some screws. And the screws you see is a C2 screw. That's a power screw. Mm-hmm. Okay. There are different. You can use a laminar screw, or you could use different screws. But I use the power screw. It worked pretty well. I think this is like 2.8 millimeters long, 28 millimeters long, and 3.5 millimeter. So I got an excellent fixation. And the other screws are ladder mat screws up there. So you put the power screws, and when I put the power screws, I do a little bit of laminotomy. I palpate the inner aspect of the C2 pedicle, make sure I'm actually putting a little more medially, because you don't want to stay away from vertebral artery, So you have to, entry point is just at the midpoint of a C2, C3 facet, just about 1 millimeter higher. That's the entry point. You drill it, and you go about 10 degree medially and superiorly. Okay. And I do progressive drilling technique. I don't use a hole, anything like that. I drill by 2 millimeter by 2 millimeter. What I learned when you do big cases like this, I usually give it some Decadron, because invariably they're going to complain of some swallowing difficulties. So if you give a Decadron, maybe a couple doses, 8 milligrams, they do better in terms of swallowing. Kind of prophylactic Decadron, for the swallowing.
Yeah, that's a very interesting case.
Yeah, that's it.